Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr Travis Brown. This is the story of colorectal cancer, part 3. Dr. Stephanie Lim is a medical oncologist with an interest in gastrointestinal oncology and translational research. Dr. Lim works at Macarthur Cancer Therapy Centre and GenesisCare, is an honorary research fellow at the Ingham Institute for Applied Medical Research and conjoint senior lecturer at Western Sydney University. Dr. Lim completed her PhD in 2017 on rectal cancer. She's involved in clinical trials, has published more than 40 peer-reviewed papers in the field of oncology, and research interests include liquid biopsies and biomarker translational research. And we'd like to thank Stephanie for being with us today on This Medical Life podcast. Stephanie, welcome.
Thank you so much for having me.
Stephanie, what are the reasons that you give chemotherapy?
Yeah, so chemotherapy is given for colorectal cancer in two different settings. I think it's useful to think about these two settings separately. So the curative setting and the palliative or metastatic incurable setting. So curative chemotherapy is given as adjuvant or post-surgical chemotherapy in colonic cancers. So the aim of this is to reduce the risk of cancer recurrence. And the rationale is that chemotherapy hopefully can wipe up the micrometastatic cells that are circulating in the bloodstream, which can ultimately seed in a distant organ and cause cancer recurrence. In rectal cancer, which is treated quite differently actually to colonic cancers, chemotherapy is also commonly given before surgery, so that's neoadjuvantly. And the aim of this neoadjuvant therapy is to downsize the tumour, to shrink it down hopefully, and to hopefully lead to a less morbid surgery in the case of rectal cancer where you're hoping to have a sphincter-sparing surgery. And neoadjuvant therapy is also very useful to what we call test out the tumour biology, to sort of have an idea of how that particular cancer behaves, and that would really determine the next steps in treatment. So that's sort of the curative setting. In a palliative setting, chemotherapy is used to treat metastatic disease that's already present, and the intent of this treatment is non-curative and is aimed at controlling disease. Having said that, though, there is a subgroup of colorectal cancer that we call oligometastatic, oligo meaning a few, so a few metastases in a few sites. And in some of these patients, surgery to resect the metastases, so a metastasectomy, in combination with perioperative chemotherapy can actually be curative as well. So that's a cure for, stage 4 colorectal cancer.
Are there any important features you consider when determining if someone needs chemotherapy or not?
Yeah, so again, let's talk about that based on the two types of chemotherapy settings that we've just been discussing. So in an adjuvant setting for colon cancers, there are features on the surgical specimen that inform us of the pathological stage and hence the risk of recurrence. So for example, a node-positive resected colon cancer or stage 3 cancer, or a stage 2, so node-negative cancer with high-risk features such as high-grade or lymphovascular invasion would be offered 3 to 6 months of adjuvant chemotherapy after surgery. In locally advanced rectal cancer, as we discussed, neoadjuvant chemotherapy is very commonly given, and this is, again, commonly given with radiotherapy neoadjuvantly. For palliative chemotherapy for incurable disease, there's lots of factors I think we need to take into account in determining choice of chemotherapy. So there's tumour factors that include the site of disease, how much disease a patient has, so the tumour burden, whether they're in vital organs like the liver, also symptom burden, how much of their symptoms is really attributed to the cancer. Patient factors include the performance status, so that's very important, and we grade that with our ECOG performance status, which really is just a measure of their functional status, and other significant comorbidities such as cardiac, hepatic, renal, that will impact as well what chemo they could have. So treatment in this metastatic setting really, needs to be balanced between controlling the cancer, prolonging life, but also managing symptoms and maintaining their quality of life while we give them chemotherapy. There's other factors that determine target therapy, but I think we'll touch on that a bit later on.
Stephanie, as the layperson in this conversation, when I hear chemotherapy mentioned, my mind turns to side effects. So what are some of the common side effects of chemo?
Yeah, of course. That's that's what all patients want to know when I talk about chemotherapy. Yeah. So I usually tell my patients that there are common side effects that are usually well managed with supportive medications, and they're usually not very serious. But there are also less common rare side effects that are serious, potentially life-threatening or even fatal. The common toxicities of chemotherapy include nausea and vomiting, but we do have a lot of very good drugs these days. And I think that's why chemotherapy is better tolerated these days. Some of these drugs haven't changed at all over decades, but the supportive medications, the anti-nausea medications, have definitely improved and evolved. So nausea, vomiting, diarrhea, skin side effects. And I tell all my patients that they will all, guaranteed, everyone will experience some degree of tiredness or fatigue. So for the common regimens that we use in colorectal cancer, such as FOLFOX, you'll hear about FOLFOX a lot if you work in GI oncology. It's a doublet, so 2 different drugs, 5-fluorouracil, which is an antimetabolite, and oxaliplatin, which is a platinum drug. Very common regimen, and it can cause neuropathy, cold sensitivity, which is quite a unique and quite an unusual side effect of chemotherapy that patients don't expect, so they have to tell them. And skin toxicities as well, like hand-foot syndrome, or what we call palmar-plantar erythrodysesthesia, where it really is just redness, swelling, or peeling and cracking of the soles of the hands and palms of the hands and soles of the feet. Chemotherapy causes myelosuppression, as we know. It attacks all the good cells, unfortunately, as well as the cancer cells. So it does drop your counts, and it can cause febrile neutropenia, which is one of the emergencies that, GPs or our medical staff all know about. If someone has a fever on chemo, they need to go to hospital. 5-fluorouracil chemo that I mentioned is the backbone of a lot of the GI cancer regimens, and it can rarely cause cardiac toxicities such as coronary vasospasms. However, the other very common question I get from patients is, am I going to lose my hair? So a lot of the GI regimens actually don't cause complete alopecia, but hair thinning is very common.
Are there any targeted therapies you have available for colorectal carcinomas?
Yes, there are several targeted therapies used in a metastatic setting, so not in an adjuvant setting. So we routinely test for RAS, BRAF, and MMR for near diagnosis of metastatic colorectal cancer. So these are biomarkers that are predictive of response to targeted therapies or immunotherapy. So RAS wild-type tumours can respond to epidermal growth factor receptor inhibitors, a bit of a mouthful, or the EGFR inhibitors, which is a type of targeted therapy we use in colorectal cancer. BRAF V600E mutant colorectal cancers can respond to a combination of the EGFR inhibitors in combination with a BRAF inhibitor. MMR is another predictive biomarker. We might touch on that when we discuss immunotherapy a bit later on. The other targeted therapy we have is bevacizumab, again, another long name, which is a monoclonal antibody that targets the vascular endothelial growth factor, or the VEGF, so blood vessels. There's no good biomarker for bevacizumab, so we use it in combination with chemotherapy.
What determines if a patient gets these targeted therapies or not?
So we've touched on this already. So the targeted therapies are given depending on the mutational status of the cancer, but also tumor sidedness. So this is another very interesting and evolving area. So what we know is that right does not equal left. The right colon is different to the left colon. The cutoff is sort of the splenic flexure. And again, I think this dates back to the embryonic origins. So sort of the midgut and hindgut are different. We know that the mutational landscape of the right colon and the left colon are quite different. And so there is data to suggest that certain targeted therapies work better for right versus left. So, for example, we use the EGFR inhibitors for left-sided cancers, and we use drugs like bevacizumab more commonly in the right-sided colon cancers.
I'm going to sound like a broken record, but when it comes to these targeted therapies, Stephanie, any common side effects they bring to the table?
Yes, Steve. So very relevant, very great question. I get asked this all the time. by colleagues as well as patients. So side effects of these target therapies are quite unique. They're different to chemotherapy. So I guess, and we've the explosion of drugs in the oncology space, it's quite difficult and it's challenging for all our medical colleagues to be on top of all the very sort of quite unique side effects of all these drugs. So for the ones for colorectal cancer, the EGFR inhibitors, the VEGF inhibitors, the EGFR inhibitors can cause an acneiform rash. It's quite a classic rash, so you can pick out the patients who are on this in a waiting room. They look like teenagers. They've got this classic acneiform rash. It can cause electrolyte disturbances, commonly hypomagnesemia. It can cause drug fever, ocular changes, can cause fatigue. All treatments cause fatigue. And rarely it can also cause cardiac and pulmonary toxicity. Bevacizumab, which is the VEGF, the blood vessel drug, because it acts on blood vessels, it commonly causes hypertension or worsening of existing hypertension, and rarely can also cause issues with bleeding and clotting.
Does immunotherapy play a role in colorectal cancer then?
Yes, so immunotherapy is pretty much embedding itself in pretty much most cancers. It's very exciting. And in colorectal cancer, there is a small subgroup, which is the MMR deficient or the microsatellite high colorectal cancer. So it's around about 10-15% of colorectal cancer would be MMR deficient. And as I said, I was listening to your podcast on Lynch and HMPCC, etc. We talked about MMR deficiencies. But essentially, these cells in this particular cancer are unable to recognize and repair spontaneous mutations. So these mutations accumulate, and then you end up with a very high tumor mutation burden. And because of all this hypermutation, you get lots of neoantigens that then activate an anti-tumor immune response in the tumor microenvironment. So it makes these cancers what we call immune hot and respond well to immunotherapy. So immunotherapy, I know Steve will ask this. I'm going to just talk about it before he does. What are the side effects of immunotherapy? So immunotherapy is generally very well tolerated, but it can cause potential immune-related side effects. How it works is that it pretty much activates your body's immune system to fight the cancer. And in doing so, you can get autoimmune side effects. And that really can be against any organ in the body. More commonly hepatitis, colitis, but it really can be anything. It could be thyroiditis, it could be myositis. And you certainly do get the weird and wonderful. Mm-hmm. So overall, very well tolerated, but we still need to keep an eye out for the autoimmune, immune-related AEs or adverse events.
Right. Well, now you're forcing me to come up with new questions now. I imagine there's no one-size-fits-all. So what determines the cycles and the duration of this therapy?
Yeah, so talking about chemotherapy, so again, let's talk about the adjuvant, the curative setting, and the palliative, the kind of incurable setting. So adjuvant chemotherapy, as we said, depends on the risk features that we discussed earlier. If it's stage 3, if it's stage 2, and the high-risk features, the duration of chemo would be 3 to 6 months. The common regimens are either 2-weekly or 3-weekly. So for 2-weekly regimens, we're looking at sort of 6 to 12 cycles of chemotherapy. For palliative chemotherapy, there's really no fixed time frame for treatment. And again, this is a very common question my patients ask is, how long am I going to be on chemo for incurable disease? So really the treatment duration is dependent on 2 things mainly. So the response of the cancer to treatment and the patient's tolerability of the treatment and their side effects. So treatment, I tell patients, we would hope to continue you on some form of treatment when we've got both, when we've got control of disease and when we've got a good tolerance of treatment. But we can have breaks from treatment, and look, that's tailored to the individual patient. And then for each line of treatment, so in metastatic disease, we go through lines of therapy. We've got different drug options we can offer patients. So for each line of therapy, we would continue until at some point when the cancer becomes resistant to therapy, and then we would need to change to a different line of treatment.
How do you measure treatment goals and the patient's progress?
Again, in a curative setting, I think after chemo completion, they start a surveillance program, which would involve regular clinic visits, blood tests. serial imaging and surveillance scopes. So I guess that's how you would monitor for recurrence. So a surveillance program that typically goes on for 5 years post completion of chemotherapy in an adjuvant setting, in a curative setting. In the metastatic setting, as we discussed earlier, I think the goals really need to be, balance between disease control, prolonging life, but also very, very importantly, the quality. It's not just the quantity, but the quality of life and how they tolerate treatment. And it's not just the side effects of treatment, but also other things like time toxicity. So we're starting to recognize that, that takes a huge toll on patients. What we call time toxicity, so the amount of time they spend in the cancer center, receiving intravenous or infusional chemotherapy, or even just driving to tests and appointments and scans, and spending their time, getting treatment in a hospital or in a cancer center. So monitoring progress for these patients would involve regular clinic visits during chemo. So typically we may see them every 3 to 4 weeks. Regular blood tests before each cycle of chemo, and I would usually do imaging, which is usually a CT scan to assess how the cancer is going every 3 months or so.
Now, aside from the questions that Steve's thrown at you, is there any other common questions you get from patients that we haven't asked at the moment?
Yes, there's quite a few that that are commonly asked. So one of them is, what's caused my cancer? I always get asked by patients, especially the younger ones, what's caused this? Did I do something wrong? Is there something I could have done, etc.? Look, most of the time we don't know. Most of the time we don't have a cause for cancer. There is a small group of cancers that we can attribute to specific mutations that we can potentially test for. But that's a small group. It probably makes up around 5% of colorectal cancers are the heritable cancers. So most of the time, it's bad luck, or it's mutations that we just don't know. We don't know yet. And sadly, cancer doesn't discriminate. I've got young, fit patients who get the disease. The other question I always get asked is, what can I eat? Is there a special cancer diet? Are they foods I need to avoid? And again, there's really no magic diet. I usually get asked, do I need to avoid sugar because we hear it feeds the cancer? That's not true. And again, it's everything in moderation. It's a normal, healthy diet.
We often talk in pathology terms about stages and looking at 5-year survival. So what are the 5-year survival rates of patients with stage 1, 2, 3 and 4?
Survival rates for colorectal cancer have improved over the years. I think we've had, certainly in stage 4 disease, we've had advancements in systemic therapy and the earlier disease with our screening program. So the 5-year survival rates for stage 1, you've got very good. It's almost 100. It's probably like, between 98% or so. I never see these patients, they belong to the colorectal surgeons. Stage 2 disease, still a very good outcome. I would say around 90%, 5-year survival. And then it falls to around 70% or so in stage 3, or the node-positive disease. And then in stage 4 disease, the 5-year survival is somewhere in the realms of around 15%. As I said, the median overall survival, I think we are making incremental gains, and we are pushing that median survival for metastatic disease out. And it's sitting around about 3 years now in contemporary clinical trials for stage 4 incurable metastatic colorectal cancer, which is in line with some chronic diseases. So we do call metastatic colorectal cancer a chronic disease now. The important thing to know is there is a range. So, that's just, I guess, the median. And there's overlap. There's a range for survival times within each of those stages.
Stephanie, now you've introduced me to the term time toxicity. When you look at these survival rates, I wonder if there's nuance in some of those calculations, because especially in stage 4, to get that balance right between, well, you might be getting a longer life, but if the time toxicity is so high, it almost seems like we're going through the motions just to tick off that longevity on the board.
Yeah, that's a very good point, because there is a lot of research now, Steve, looking at patient-reported outcomes or patient-reported quality of life, and there's scores that we actually, can measure. And so in lots of trials these days, one of the biggest aspects is aside from, yes, the side effect profile of drugs, etc., is what is the patient's quality of life? So there are standardized questionnaires, like the EORTC questionnaire, quality of life scores that we actually do measure. And yes, that is a very important part of balancing. We talk about what is clinically meaningful. So we talk about when we look at a trial and we look at, is there an improvement in disease-free survival? And then is there an improvement in overall survival? We also then want to look at, is there a detriment or an impact in patients' quality of life? So yes, that definitely is factored in when we, decide what really is a meaningful clinical benefit for newer drugs.
Are there any signs in or during treatment that are particularly good or bad prognostic signs?
So during chemotherapy for metastatic disease, I usually look at three things. So I look at how patients are tolerating treatment and their symptoms from disease, so how they are doing clinically. Secondly, we look at blood tests and tumor markers such as CEA may be helpful to track and look at trends. And thirdly, we look at progress imaging, which is usually with serial CT scans, as I mentioned. So if I see my patients, sort of every month in clinic, and clinically they are getting worse, they're getting more symptom burden from cancer, and it's not just side effects of therapy, or their blood tests, such as their liver function, worsen in context of known liver metastases, or they developed a biliary obstruction from known liver mets, or their cancer markers continue to rise, those are all poor or bad prognostic signs, and sadly, the CT usually would reflect that when that gets done.
In closing, are there any final thoughts or advice you have for doctors or patients about oncology in colorectal cancer?
So I think like many cancers, colorectal cancer, we know now, is not just one disease. As I said, even the right colon is not the same as the left colon, but colorectal is definitely not one disease. It's lots of different diseases that are molecularly different and are treated differently. So there's the BRAF mutant tumours, and then there's the DMMR tumours, and then there's the left-sided RAS wild-type tumours. And, as I alluded to, we're making incremental gains. I think with every drug, with every combination of drugs, we make small incremental gains. But you add up all those incremental gains, we are pushing overall survival up to sort of 3 years and beyond, with our therapies. The other exciting thing is the use of circulating tumor DNA, or ctDNA, to assess for the presence of cancer. So very promising, and I think there's definitely, this assesses minimal residual disease, which I think will probably change how we look at adjuvant therapy. So we can use ctDNA. I'm hoping that, in the future we could measure ctDNA, and that would tell us whether or not a patient needs adjuvant therapy, rather than relying on the pathological variables we discussed earlier. ctDNA can also be used to monitor disease response in metastatic disease in real time. You could do serial, blood tests. We can't really do serial biopsies on patients. So you could monitor how they're going on treatment. You could monitor for progression earlier than you could do on a CT scan. You could monitor for resistant mutations. So I think, we're certainly definitely moving towards a more truly personalised approach to the treatment of colorectal cancer.
Well, there's a positive note to end on. Dr. Stephanie Lim, thank you very much for taking time out for This Medical Life.
It's been a pleasure to chat with you both.
Dr. Meredith Johnston is a radiation oncologist. Dr. Johnston is involved with the Liverpool Hospital, Liverpool Cancer Therapy Centre, Campbelltown Hospital and Macarthur Cancer Therapy Centre. Dr. Johnston is an active member of the multidisciplinary cancer care team, attending regular meetings and discussing patient care, including colorectal cancer, the topic we're discussing today. Meredith is our guest on This Medical Life podcast. Meredith, what are the important features you consider when determining if someone needs radiotherapy or not?
When we're talking about using radiotherapy for colorectal cancer, we're usually talking about rectal cancer, so lower down in the colon, right at the bottom end, rather than higher up in the colon. And this is because rectal cancers are located low in the pelvis, where there are these very narrow soft tissue planes. And there's a higher risk of cancers coming back in the pelvis, in either where they started in the rectum or in those lymph glands around the rectum, because of those narrow soft tissue planes after someone just has surgery to remove a cancer there. So the role of radiotherapy is principally to reduce the risk of the cancer coming back in the pelvis following surgery. So not every patient with rectal cancer needs radiotherapy. However, for those that do, it is best that it's given before surgery rather than afterwards. It is really crucial that these patients are discussed in a multidisciplinary tumour board, which is also known as an MDT, because these patients require a truly multidisciplinary approach with surgeons, radiation oncologists, medical oncologists and radiologists and pathologists who review each case to determine what the best treatment pathway or treatment package is. So there's a number of things that we consider when we're deciding about radiotherapy for patients who have rectal cancer, and this should be decided before the patients have any treatment at all, because as we said, radiotherapy is usually given before surgery. So we consider factors related to the tumour, including its location, so whether it's very low in the rectum. Essentially, the lower the tumour, the more difficult the surgery, because the pelvis gets narrower and closer to the external opening or the anus. And therefore, the higher the risk of having positive surgical margins and local recurrence without the use of radiotherapy. So those very low tumours are what we say are higher risk. And we also look at the imaging to see how deeply the rectum, the tumour's penetrating into the rectal wall or through the rectal wall or into other structures, and that's something called the T stage. And we also look at whether there are lymph nodes around that kind of pelvic area where the tumour is, so whether they're involved and the number and location of those. Of course, we also need to consider whether there's any signs of metastasis and other patient factors like their fitness for treatment, so whether they have other medical comorbidities or other medical problems. And the way that the combinations of treatment are being given for rectal cancer has also evolved quite quickly in the last 5 years or so. So there are now more options to be considered, like giving chemotherapy and radiotherapy before surgery, giving an intensive combination of chemotherapy as well as radiation, and in some cases, whether the patient can avoid surgery altogether with the use of combination chemotherapy and radiotherapy, although that's still a evolving, developing area.
Just looking at the actual physical action of radiotherapy, how does it work?
I might explain a bit about how radiotherapy treatment's carried out to explain that, because for a lot of people, that's including many doctors who don't work in the radiation area, that is a bit of a mystery. So hopefully I can shed some light on that for you. So the main type of radiotherapy that's used in treating rectal cancer is what's called external beam radiotherapy. This is ionizing radiation, so it's like high-powered X-rays, which come from outside of the body. It has to be carefully planned and tailored to each patient using a planning simulation. We call it a simulation scan. It's a planning CT scan, which is done with the patient in the treatment position. And we use these planning CT scans and usually an MRI scan as well to map out the target area and also what we call the organs at risk, which are the other organs in the region of the pelvis that we aim to spare from radiation. And this helps to minimize side effects. So then a radiotherapy plan is generated using special planning software and the expertise of our technicians who are radiation therapists and also medical physicists. And when a patient then comes for treatment, what they will do is they lie on a treatment bed, which is like a CT scanner bed in a specially shielded room. And the position of the patient is exactly the same each day, and it's corrected so it's just in the right position each day. And then the treatment's delivered by a machine that moves around the patients delivering treatment beams. And treatment time is usually only a few minutes, although the patient is in the room for more like 15 minutes for each session. So what happens when that treatment beam is turned on is that ionizing radiation enters the body at precise locations which are targeted, and it deposits its energy, causing breaks in the cancer cell DNA, which aren't repairable, and the cells then die. So the cancer cells die. And it should be noted that damage is also caused to the normal cells in the area. So normal cells can also experience damage from radiation, and that's how the side effects of treatment occur. However, the normal cells have a greater capacity to repair and recover. So the cancer cells will die off. The majority of the normal cells will repair and recover, and that's how we get the effect of radiotherapy in terms of killing cancer cells.
Who determines who gets radiotherapy and who doesn't?
This kind of goes back to what we spoke about. What we're trying to determine is what the risk is for the cancer coming back inside in that region of the pelvis. And in the case of the rectal cancer, we need to determine this at the outset using all the information from investigations that have been done. So that's a colonoscopy, that initial look inside, and usually the time that the biopsy is taken. The pathology from the biopsy, so what the cancer actually looks like under the microscope. The radiology, so including the CT scan, MRI scan is usually very helpful, like I mentioned. And sometimes the patient will have a whole body PET scan as well. And that looks at kind of activity of the tumour and can help pick up any signs of, particularly of the cancer having spread to other parts of the body. So we also need to know what kind of surgery is anticipated for removal of the tumour, so what the surgeon is planning to do. And then, of course, we look at other factors like we mentioned, like patients' other illnesses or what we call comorbidities. So when we look at all that information about the patient's surgery, their tumour, and we estimate that they have a relatively high risk of the cancer coming back if, for example, they just had surgical treatment. And so this includes those, remember we talked about the low rectal tumours that are close down to the anus, particularly if they're within 5 centimetres of the anus itself, or they're deeply penetrating through the rectal wall, or there's lots of abnormal appearing pelvic lymph nodes. Then those are the cases when we really do need to consider and recommend radiotherapy that's best done before surgery. There's also some patients for whom what we call non-operative management may be preferred. So patients who would otherwise need to undergo what we call an abdominoperineal resection. So when the tumour is very, very low and close to the anus, the patients may not be able to have their bowel rejoined up, and so they end up with a permanent colostomy. And so some of those patients are really kind of keen to say, look, is there a way that I can avoid having surgery? And so at the moment there's, some evolving evidence to say that we may be able to spare some patients from surgery using a package of chemotherapy and radiotherapy to really intensively try to reduce and kill off all the cancer without surgery. Like I mentioned previously, this is still a bit of an area in evolution. It's not a standard treatment yet to be able to avoid surgery, and the majority of patients will still need to have surgery for their cancer, and that's what we will tell them.
What type of doses are we talking about that patients receive?
So most patients receive about 5 weeks of radiotherapy in 25 sessions, which are done like Monday through Friday. And this amounts to what is called 50 gray of radiotherapy. So that's the kind of doses that we're usually talking about. Standardly, most patients will also receive capecitabine, which is an oral chemotherapy agent, which is also a type of chemotherapy that can be given with radiotherapy. And they'll receive that on the radiotherapy treatment days to sensitize the cancer cells and improve the effectiveness of radiotherapy. So that's kind of the standard kind of radiotherapy treatment course. There's also a type of regimen that is called short course radiotherapy, and it's given in 5 sessions over 1 week using a lower total dose of 25 gray, so kind of half the lower dose. But because it's given over a shorter period of time, it actually amounts to a kind of almost equivalent dose. But this is for various reasons. It's less frequently used as it's only suitable in very selective cases. Typically, the more standard way is to give the smaller doses per day over 5 weeks.
Meredith, you hinted at side effects earlier. I wonder if we could just come back to them now. What are some of the common or important side effects we need to know about?
Yeah, so this is something that we need to talk to all of our patients about who are undergoing or about to undergo a course of radiotherapy. So common side effects with radiotherapy really relate to the area that's being treated. So they're not, largely they're not general side effects. They're kind of related to the area where we focus the radiotherapy on. So in this case, the pelvis for rectal cancer. So what happens is that due to the effect of radiotherapy, other organs and tissues in the pelvis become inflamed, so to speak, with radiation during the treatment course, and this causes the side effects that are noted. The side effects come on gradually during the treatment course, so they're often not noticeable until the second or even third week of radiotherapy. They begin quite mildly and may become more pronounced by the end of treatment, but generally this kind of treatment is pretty well tolerated by most patients. The kind of side effects that patients can experience commonly include what we call proctitis, which is rectal inflammation, and this can cause symptoms of incomplete emptying or small frequent bowel motions, so needing to go to the toilet just to kind of pass a bowel motion but not much coming out. Sometimes a little bit of discomfort can be associated with that too. And patients can get some mild diarrhea, although this is usually not prominent. They can get some cystitis symptoms, so bladder irritation causing burning and stinging when they pass urine. Mild nausea is a side effect that we see relatively infrequently, actually. Some mild loss of appetite, mild, in this case, skin reaction or reddening can occur in the buttock cleft. And most patients actually will feel quite tired. So that sort of fatigue side effect of radiotherapy is quite common, and it's most pronounced at the end of the treatment course. So all of these kind of what we call acute side effects are those ones that happen during the treatment course, and they typically resolve in a few weeks after the treatment, although the fatigue that I described can last for about a month or so. There are some longer-term side effects as well that we also need to tell patients about because those are important. They can be lasting side effects of radiotherapy. They tend to be less common. So these can include things like bowel urgency, so having to rush to the toilet, for example, in about 10% of patients. And this can also very much depend on the type of surgery that the patient has had. So how low the joint is when a patient's had surgery and they've had the rectal tumour removed. If the joint is very low or close to the anus, that leads to a higher risk of that kind of bowel urgency or even, bowel accidents happening. There's a small risk of just related to the radiation of what we call small bowel stricture, so scarring on the small bowel that sort of sits in the pelvis close to the area that we're targeting with radiotherapy. And so in about 5% of patients, they will get some scarring or fibrosis on the small bowel, and this can cause a bowel obstruction that can happen months or even years later after radiotherapy. The other side effect that's rare but important to mention for particularly our younger patients who are undergoing radiotherapy is that there is a rare risk of secondary radiation-induced malignancy in tissues that are receiving radiotherapy. So patients can form another cancer in those tissues, and that can happen years or even decades after having had radiotherapy. Because that risk is very small, it's typically accepted because radiotherapy has a much larger benefit in preventing that known cancer coming back. And both chemotherapy and radiotherapy can affect patients' fertility, and this can be a consideration in some younger patients.
Meredith, all of those side effects I could play along at home and connect the dots with, except for fatigue. That seemed counterintuitive to me. What is the mechanism, do you think, that radiation therapy can lead to a sense of fatigue? What's going on there?
Yeah, so that's kind of $1 million question, Steve. There's been quite a lot of research that's gone into that particular question, and it is thought to be probably related to something like an inflammatory effect causing cytokine release in the body. So particular proteins and signaling chemicals, etc., that are released from damaged tissues and run around the body and then cause that effect, which is sort of a little bit, akin to what might happen when you have a bad case of the flu or something like that, and you have a mechanism by which damaged cells release these cytokines which travel around the body and cause this generalized effect. It's probably in some ways adaptive in that the body is trying to recover from a serious kind of tissue injuries, and so the body is forced to rest and recover. But yeah, we don't actually have a complete understanding of how that occurs.
What are some of the common questions patients ask when they come to see you?
Probably the most common one is, where will I park?
Always an important one. We always forget that, although doctors often say that as well.
Yeah. But seriously, they're often worried about the logistics and practicalities around coming for treatment every day for a number of weeks. And for this reason, most of our treatment centres have support services like cancer care coordinators who are really crucial in supporting patients through their cancer journey and assisting with some of these practical concerns and logistics. Patients will also, obviously want to ask about treatment side effects, and we will go through those. Another common thing that they'll ask is if there's anything special that they should eat during treatment, and anything that sort of can help with diet-wise, that can help to reduce cancer growth. Some people have done a lot of kind of internet Googling and will want to ask us about magical diets that they can have. And what we do is give them some general advice around nutrition, and we also typically will involve our dietitian to help them with maintaining their nutrition during treatment. Another common question is patients will often ask if they're able to interact safely with kids and grandkids while they're undergoing treatment. And so we tell them in terms of external beam radiotherapy that, yes, they are very safe to do so, as they don't hold any radioactivity in their body with this particular kind of radiation.
A lot of doctors will be seeing patients going through radiotherapy. Is there any important features or aspects that doctors who aren't the treating team should know about or ask patients about or even test for during their radiotherapy?
There's no specific kind of tests that need to be done. I think it is important for the doctor to know where in the body the patient is having treated with radiotherapy, and usually the patient should be able to tell them that. So in this case, the pelvis. And whether or not they're having any other treatments like chemotherapy at the same time. That way, if the patient's experiencing any symptoms, it can give a clue if they might be related to the treatment or whether there's something else going on that should be investigated. Sometimes we as radiation oncologists are asked whether, radiation to the pelvis is causing some, other side effects in the mouth or, some body part that's quite distant from the radiation. And we have to explain that, no, that's not related to the radiation. We need to kind of look at that separately and see what the cause is.
Are there any patients who are not suitable for radiotherapy?
Yeah, so in some cases there may be patients who, despite having indications for radiotherapy, aren't suitable for having radiotherapy, or in whom radiotherapy should be used with a deal of caution. So, for example, patients who have inflammatory bowel disease, such as Crohn's or ulcerative colitis, that I think you might have talked about in the podcast, these patients are more prone to very pronounced or severe bowel side effects from radiotherapy. So it's not that radiotherapy cannot be used in these patients, but we need to be very cautious about kind of what areas we're treating and counsel the patients quite carefully about, what their risks and benefits from radiotherapy are. Other patients who have connective tissue diseases like scleroderma, we have to be very careful for the same reasons. And we'll, again, weigh up those risks and potential benefits of radiotherapy. And that, again, relates to kind of potentially more severe side effects. There may be patients who are sometimes on certain medications like methotrexate for arthritis that we generally suspend, so we'll generally stop the methotrexate in consultation with the patient's relevant specialist, of course, during radiotherapy. And finally, I guess patients who are pregnant cannot undergo radiotherapy. And so we also need to discuss the impact on fertility, like I mentioned, for those women who are in childbearing years.
Meredith, this has been absolutely eye-opening. My goodness. Do you have any final thoughts or advice about radiation oncology in regards to colorectal cancer?
Yeah, look, what I'd say is it's a complex and quite rapidly evolving area in recent years. I think it's great in many ways as patients now have more treatment options, and we are looking at ways to do things like preserve organ function. So like I talked about, sparing patients from an operation, and also to reduce these longer-term side effects. So it's really vital that these patients are discussed in an MDT. Remember, we talked at the beginning about multidisciplinary care and multidisciplinary teams, so that we can provide the best treatment plan based on all the information and consensus from an entire team of specialists. I think it can also be a little bit confusing for patients to understand the different treatment packages and different options and how those are selected. And that's really where the importance of having other supports in our cancer care team, like these cancer care coordinators who can help support patients really through their cancer journey, as part of that multidisciplinary team.
Dr. Meredith Johnston, thank you so much for being part of This Medical Life.
Thank you very much for having me on the podcast. It's been really great to talk.
Dr. Emilia Ip trained as a medical oncologist before subspecialising in cancer genetics. She's a staff specialist in cancer genetics at Liverpool Hospital, which services southwest Sydney, and co-chair of the EVIQ Adult Cancer Genetics Reference Committee. And Emilia is our guest here on This Medical Life podcast. Emilia, when do cancer geneticists become involved in colorectal carcinoma?
A person who has no personal diagnosis of cancer may be referred because their doctor is concerned that their family history of cancer may be due to a hereditary cancer predisposition syndrome. In these families, there are multiple relatives diagnosed with bowel cancer at younger than expected age, and by young we mean below about age 50. There may be a history of colorectal cancer and other cancers or non-malignant features suggestive of a particular syndrome, or there may be a history of multiple bowel polyps. So in this situation, the Cancer Genetics Clinic provides an assessment of whether an underlying condition is possible and arranges genetic testing if that's indicated. In the second scenario, the person referred to us already has a diagnosis of colorectal cancer, and there are specific histopathologic findings suggestive of a hereditary cancer syndrome. This includes immunohistochemical evidence of DNA mismatch repair deficiency in the tumour tissue, or the presence of multiple polyps or rare subtypes of polyps. We also receive referrals when the person was diagnosed with bowel cancer at very young age, for example, under age 40. And in the third scenario, a hereditary colorectal cancer predisposition syndrome has already been identified through genetic testing of a relative, and the person is referred to our clinic to discuss the option of predictive testing. Predictive testing is variant-specific testing or mutation-specific testing to determine whether or not the person has inherited the familial gene fault. If they have inherited the familial gene fault, then they can pursue risk management strategies for the early detection of cancer or prevention of cancer.
Is there a difference between familial colorectal carcinoma and colorectal carcinoma associated with germline predisposition?
Yes, there is. So taking the second one first, colorectal cancer associated with a germline predisposition refers to situations where there is a heritable pathogenic variant or mutation in a single gene, and this gene fault puts that individual at increased risk of developing bowel cancer. Other cancers or non-tumour features may also be present for that particular syndrome. And descendants who inherit the specific gene fault also inherit the cancer predisposition syndrome, whereas those who do not inherit the specific gene fault do not inherit the high cancer risk. So familial colorectal cancer, on the other hand, refers to situations where there are multiple closely related individuals who have been diagnosed with colorectal cancer. The diagnoses often occur above age 50 and there are no tumour or additional features that are particularly suggestive for a hereditary syndrome. And this accounts for around 10 to 20% of colorectal cancer cases. An inherited single gene cause has not been identified in these families, and the cause of the family history is more likely to be multifactorial. So this may include complex hereditary factors such as polygenic risk, or shared lifestyle factors such as obesity, poor diet, smoking, or environmental contributors, for example, gut microbiome.
Is there some predisposition syndromes that lead to colorectal cancer?
Yes, so Lynch syndrome, which has previously been known as hereditary non-polyposis colorectal cancer, or HNPCC, is the most common of the germline colorectal cancer predisposition syndromes and accounts for around 3% of cancer diagnoses, so it's still quite rare. And then we also have the polyposis syndromes, which account for about 1 to 2% of bowel cancer diagnoses. So the polyposis syndromes can be further subdivided according to the types of polyps most commonly encountered. So where polyps are predominantly adenomas, we have familial adenomatous polyposis, or FAP, and the recessively inherited MUT-YH-associated polyposis. If we have hematomas found, then there are a few syndromes that may be attributed to this, and that includes P10 hematoma tumor syndrome, also known as Cowden syndrome, which is due to a P10 mutation, Peutz-Jeghers syndrome, which is due to STK11 mutation, and juvenile polyposis syndrome, which is due to mutation in BMPR1A or SMAD4. And then the third main subgroup of polyposis syndromes is serrated polyposis syndrome. And individuals who satisfy the WHO clinical criteria for this syndrome have multiple sessile serrated polyps, serrated adenomas, and hyperplastic polyps. SPS is often grouped with the hereditary syndromes as it may be familial, and relatives appear to have a higher risk of bowel cancer, but only a minor proportion of cases have been linked with a single gene cause, and so single gene genetic testing is generally not indicated.
You've thrown a number of names out there, and I'm sort of trying to work out how we fit this all together. What are the conditions that are the most important for doctors, I guess, general practitioners to know about?
So I think of the above-mentioned syndromes, the most important for doctors to have a bit more of a detailed knowledge is Lynch syndrome and the adenomatous polyposis syndromes, in particular FAP.
When we're considering some of those diagnoses, so Lynch syndrome and FAP, how would someone recognise that this may be something that's on the agenda for this patient?
Yeah, so taking the Lynch syndrome first, I think firstly, I'll just sort of talk a little bit about more about what that is. So Lynch syndrome is a dominantly inherited condition, and affected families have a germline pathogenic or likely pathogenic variant in one of the DNA mismatch repair genes. So these genes are called MLH1, MSH2, MSH6, and PMS2. And the cancer risks associated with each of these genes varies. So, in general, Lynch syndrome due to MLH1 or PMS or MSH2 have higher colorectal cancer risks in the range of around 40 to 50% lifetime risk compared with Lynch syndrome due to MSH6 or PMS2, which have lifetime colorectal cancer risks of around 12 to 20%. Lynch syndrome also predisposes to other types of cancers. So the highest lifetime risks are for endometrial cancer and are around 40% for MLH1, MSH2 and MSH6, followed by ovarian and gastric cancers. There may be increased risks for urothelial carcinomas, and particularly those of the renal pelvis and ureters, although it may also include the bladder. Pancreatic cancer, small bowel cancer, and rarely brain tumours, especially glioblastoma, have been reported at higher than expected frequencies in Lynch families, although the absolute risk of developing a brain tumour remains small. Sebaceous adenomas are benign skin tumours which are represented in a variant of Lynch syndrome called Muir-Torre syndrome. So armed with this background, we can consider Lynch syndrome in families where there are multiple individuals or a single person who has multiple cancers diagnosed and the cancers are part of this Lynch syndrome spectrum. Particularly for bowel and endometrial cancer, the diagnosis should be at younger than expected age. So if the average age of bowel cancer in Australia is around 70 years, in Lynch syndrome, the average age across all of those 4 different genes is around in the 40s. Because we know that from many studies that family history of cancer can be an unreliable indicator of hereditary predisposition syndrome, it is now more common for potential Lynch families to be identified through tumour testing. So the DNA mismatch repair proteins can be visualised via immunohistochemistry in the tumour tissue, and when staining for one or more of these proteins is absent, then it raises the question of Lynch syndrome as one of the potential causes for mismatch repair deficiency. DNA mismatch repair immunohistochemistry is now tested as standard for newly diagnosed colorectal cancers and in many centres for endometrial cancer as well. So another thing that clinicians may have also heard is of MSI high or microsatellite instability high colorectal cancer. So the DNA mismatch repair genes are one of the DNA repair pathways in our cells, and microsatellites are short repeated DNA sequences and are particularly prone to replication error in the context of DNA mismatch repair problems. So MSI testing involves polymerase chain reaction, PCR, of 5 microsatellites in the tumour tissue, and the length of the microsatellites is compared to normal tissue. So if the length of the microsatellites is altered in at least 2 of the 5 microsatellite areas, the tissue is labelled MSI high. If one is affected, it's MSI low, and if none of the microsatellites are altered in the tumour tissue compared with normal, then the tissue is microsatellite stable. So this is another way of detecting possible Lynch syndrome that looks at the end result of DNA mismatch repair pathway failure, rather than immunohistochemistry, which looks at the protein products of the Lynch genes. In either case, germline testing must be done to confirm whether the underlying cause is Lynch syndrome or mismatch repair deficiency, or microsatellite instability is due to a sporadic cause. So that's Lynch syndrome. And then in terms of familial adenomatous polyposis, this is also a dominantly inherited condition and is associated with the germline APC gene pathogenic variant. So in classic FAP, polyps may start to develop in the teen years, and individuals may go on to develop hundreds or thousands of polyps throughout the colon. For individuals with an attenuated form of FAP, the total number of polyps is less and may be up to the low hundreds, and the age of onset may be higher. So the presence of polyposis confers a higher risk of developing bowel cancer with a lifetime risk of over 95%. Careful surveillance of the colon with polypectomy and colectomy once the burden of polyps becomes too high to safely remove reduces the risk of progressing to colorectal cancer. Other FAP-related tumours include polyps in the stomach and duodenum, duodenal cancer, abdominal desmoid tumours. Less common associations include thyroid cancer, childhood hepatoblastoma, and brain tumours. Non-tumour features of FAP include congenital hypertrophy of the retinal pigment epithelium, osteomas, epidermoid cysts, and abnormal dentition. So the presence of multiple adenomatous polyps are the main reason to consider FAP. If a person has between 20 and 100 polyps, there's around a 10% chance of identifying an APC gene fault. If there are over 100 polyps, then APC gene faults will be identified in around 60% of individuals. The main non-polyp reasons for FAP assessment include diagnosis of abdominal desmoid tumours, particularly in young people, or referral from an ophthalmologist due to finding of congenital hypertrophy of the retinal pigment epithelium, which in FAP is multifocal and or bilateral.
Now, we're looking at testing for genes. Is there any genes that provide targets for potential treatment plans?
Identifying a cancer predisposition syndrome traditionally provides information on individual cancer risk, and along with that, implementation of screening for early detection and prevention. And this is to empower individuals and families with this information as a core goal for our cancer genetics clinics. However, I think you're alluding to an exciting new area of cancer genetics where genetic predisposition may inform treatment in an age of personalised medicine. So the presence of DNA mismatch repair deficiency, whether due to an underlying Lynch syndrome or sporadic cause, is associated with good prognosis in colorectal cancer. And there's evidence that adjuvant chemotherapy is not beneficial for individuals with DNA mismatch repair deficient early colon cancer that is lymph node negative. In the last couple of years, immunotherapy drugs have produced very impressive response rates for DNA mismatch repair deficient cancers. In metastatic colorectal cancer, response is observed in almost half of individuals, and for those that respond, it may be a durable response. Smaller studies have also shown promise in other settings as well, including the neoadjuvant or pre-surgical treatment of locally advanced rectal cancer. And immunotherapy response is not limited to colorectal cancer, as DNA mismatch repair deficiency, irrespective of tumour location, has been correlated with responses.
Looking at clinical genetics as a whole, is there any time that you think that doctors should contact clinical geneticists to ask, or that we're missing in our practice to ask for advice?
So I think specialists are good at referring new patients with tumour DNA mismatch repair deficiency or in the presence of polyposis, and definitely multidisciplinary team discussions are an excellent way for identifying new patients. But I think there are two situations where there may be some missed opportunities for referral. So in the first situation I'm thinking of, there may be a syndrome with a very strong clinical phenotype, such as FAP, and a clinical diagnosis of FAP may have been made many years prior in a family, but without any genetic testing performed to identify the specific gene fault. It's useful for these families to be referred because having the option of predictive testing for relatives to identify whether or not they have inherited the APC gene fault prior to them developing the phenotype can help clinicians to provide appropriate risk management to carriers. Similarly, relatives who know that they have not inherited the gene fault at an early stage don't need to start regular colonoscopy screening, which is obviously beneficial for the patient, but also for the health system. Another more common situation is where there is a known germline gene fault in the family, but the eligible blood relatives have not yet been tested. Sometimes it's because relatives are not aware, or because they don't know how the knowledge of their genetic status could empower them to be proactive in their healthcare and manage a cancer risk that is present whether they know about it or not. When there's a suspicious family history but your patient is not sure about whether or not genetic testing has happened, the first step may be to encourage your patient to speak with their relatives and ask about whether genetic testing has occurred in the past. Even if genetic testing has not occurred, this can be a vital first step for families to start a conversation and start gathering accurate information regarding the specific family history, cancers, age at diagnoses for their relatives. When patients have heard that there is a gene fault in the family but are unsure about whether they want to have genetic testing performed, referral to a cancer genetics clinic is actually the best place to start. We are positioned to be able to explain to them what the gene is, what the known cancer risks are, and importantly, if they're found to have inherited that cancer risk, how they can manage that risk. We don't tell patients whether or not they should have the genetic test, but can help them understand the genetic test so that they can make an informed decision about whether or not they want to pursue testing, defer their test, or decline the genetic test altogether.
Do you have any final thoughts or advice about clinical genetics in colorectal cancer?
Yes. So cancer genetics clinics spend a lot of time looking for and counselling around rare syndromes. But in doing this, we also need to remember the importance of educating patients about how lifestyle factors can influence their cancer risk. So many individuals are not aware of the impact that these potentially modifiable factors, such as having a healthy diet, doing regular exercise, maintaining a healthy weight, not smoking, and limiting alcohol intake can have on their cancer risk. When I meet with parents who are worried about the cancer risk of their children or their teenagers, one of the key things I always discuss with them is how important this time of their lives is in setting up healthy lifestyle habits. Lifestyle is an important consideration even when there is a hereditary predisposition syndrome, and evidence for this comes from a study looking at the role of aspirin in the prevention of bowel cancer and Lynch syndrome, where there was a higher risk of bowel cancer in obese versus non-obese individuals.
Just when I think we've hit the extremes of what's fascinating in the world of medicine and science, we get it pushed out even further. Dr. Emilia Ip, thank you so much for joining us on This Medical Life.
Thank you very much.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.